Welcome back, everyone. I hope you had a good break. For our next session, we will have a KAND symptoms Q&A. And over the past few weeks, we've been gathering questions on this topic from the KAND family community. And now we will have Dr. Wendy Chung and Dr. Leah Boyle, who we all met yesterday, as well as Dr. Jennifer Bain, who's a neurologist at Columbia University, collaborates with the Chung Lab, and who some of you may remember from our community calls that we've had in the past on the stage with Dr. Dennis, who we just met as well. As a reminder, people can submit questions live if you want to use that Q&A function. However, if we don't have time to address all of your questions, we do have plans to follow up with the family community after the conference.
Hello, everyone. So for the next hour, we'll be talking with our experts about KAND symptom questions. Again, the caveat is that every patient's unique, but we have a ton of questions from you, and we're going to make sure that they land on the ears of the most qualified people to answer them. The first question I have is, do children cognitively regress or decline with this disease? And I think a couple of you could probably yield this.
Hi, Shannon. Thanks for having us back. Sorry, some technical difficulties, still getting used to this platform on my end. So the question is about cognitive. Sorry, I'm reminding myself of the question. Do children cognitively regress or decline with the disease? That was the question. So this is something Dr. Chung has talked a little bit about yesterday, and we don't know, unfortunately, like a lot of the other things. This is something we do see over time in some cases, that individuals will plateau, and the rate of gain of knowledge can look different for everyone. But we really still need more information from all of you to be able to tell whether there's a true decline or whether it's a lack of gains, I guess I would say.
If you could, from a severity for vision loss that we can't.
Yeah, so this is something where we've really seen people all across the spectrum. So there are some individuals who really from birth, as far as we can tell, had very limited vision. There are other individuals who might have had typical vision at birth, and then over time their vision declines. The other thing that's important to think about is the different components that can contribute to vision problems. So in some cases, there are things like optic nerve atrophy or cortical visual impairment, like we discussed yesterday. There are also things that can happen. People with KAND can need glasses, just like you and I here. People with KAND can also get cataracts, and that's something where the important thing to think about in terms of some of these vision problems, what can we do something about, and what are we not currently able to do something about? So something like, if you need glasses, that's wonderful, you can get glasses and that can help. Or sometimes for people who have cataracts, cataract surgery can really be life-changing if that's a large contributor to the vision issues. But that really depends on the person, and this is part of why one of the other things that we do recommend is getting regular vision checkups, especially for people who have any vision difficulties. And Dr. Chung can speak more to that if she has anything to add.
Sorry.
Okay, thank you. One of the other is therapy, if at all, can it stop your battery? Anybody?
So maybe I'll take that, and I'm sorry, I got lost somewhere back there. So the vision therapy doesn't do anything in terms of the actual optic nerve. So it doesn't slow down the progression of the condition or any degeneration. What it does is it teaches people how to be able to accommodate the problems that they have with their vision, and in part for us to be able to build the environment around someone so that it's safe. And so that's really what vision therapy is in terms of doing that. So whether it's things in terms of being able to have larger font, if you just want to think of that, you know, in terms of bigger text that you can read, more contrast in colors so that when it comes to safety, some things like on steps are very clearly discernible. But that's really more what vision therapy is. It's not going to change the actual sort of neurological process.
Hi, it's Jennifer Bain. I'll chime in a little bit. It's great to be here. What I'll add on to kind of what Drs. Chung and Boyle were speaking about is vision is very complex. Starts with the structure of the eyes, goes to the nerve, going back to the brain, and then the brain itself. And it sounds like to me that the spectrum of disorder is from the eyes all the way back to the brain, and it can kind of you can hit road bumps anywhere along the line. And so when it comes to the eyes, obviously making sure that they're lined up correctly and they're focusing correctly, addressing cataracts, any kind of abnormal, what we call dysconjugate J's or strabismus. So those are things that we can fix. The nerve itself, we don't have any evidence that there's a treatment to prevent that from being affected. And then in the back of the brain, we're talking about that cortical visual impairment. And again, I think we're not really at a point where we understand medicines or treatments to affect the nerve or the brain. Vision treatment per se, vision therapy per se is, again, I completely echo Dr. Chung's comments. It's not going to address the eye, the nerve or the brain. It will make sure that we're getting the best input as we possibly can get. One comment I will have is that the cortical visual impairment diagnosis and the optic nerve diagnoses are really only made by ophthalmologists and specialized treatment providers. So, you know, if you go to your pediatrician, they're really not going to be looking deeply at the eye. They're not going to be looking back at the brain. And so making sure that you see a good provider who feels comfortable making those diagnoses is important. And the cortical visual impairment is a very special diagnosis that's made clinically by people who are comfortable and confident in diagnosing and treating that. And by making that diagnosis, while a lot, maybe the older people haven't gotten that diagnosis, it might be there. It might not be that, you know, just because you don't have it, you don't have it. It also might be that we didn't look for it. And so a lot of times providing an evaluation for that specifically could be very helpful in providing exactly what Dr. Chung was noticing. Or noting before, that perhaps certain colors would be better, fonts would be better, recognizing that the visual field might be more like this, not like this. And so really providing those types of therapeutic support for an individual really is going to be important, I think, going forward. But because obviously the 100 or 200 people here haven't been seen by the same eye doctors, it's a little bit unclear right now while we're still collecting that data. But anybody who's had those evaluations, I think sending that to the group is going to be really helpful in moving forward and better understanding the spectrum of the eye issues.
Absolutely.
Shannon, thanks. It's nice to see you, Shannon. I'm back up in case your internet doesn't cooperate anymore.
You gotta love Michigan sometimes. Basically Canada. Apologize, everyone. We get continue to help with ataxia, and are really have caused major injury. And wise.
As a neurologist, we get this often. I would say first and foremost is therapy. So therapy, that's probably occupational therapy and motor and physical therapy. And I think recognizing where our weaknesses are and being aware of that. So one piece of ataxia, which is unsteady balance or unsteady gait, sometimes people walk with their legs a little bit wider to try to balance a little bit. That really, it could be a problem specifically with the brain. And so even therapy alone might not be enough. There's not really therapy or there's no medications necessarily for ataxia or that unsteady gait. But there are other things that you can do to kind of help stabilize that. That might be specific bracing, that might even be specific equipment to help individuals. When there's extra movement, meaning abnormal movement, somebody, I think in the comments, made a comment about dystonia. So your body's doing things and your brain's doing things that you're not intending on it to do. There are potentially medicines that could be helpful for some of that. Absolutely, this is something, going back to Dr. Dennis, that you need to go to your provider to speak with. But I think first and foremost are therapies. Second is making sure you're getting your correct braces and equipment around you. And then third is really being understanding and recognizing your environment and what your goals are in terms of, you shouldn't be having your child or your loved one walking downstairs without obviously the appropriate support and people around them. And then I'd say last would be potentially there could be some medicine, but not for all of these types of treatments.
So just to echo and reinforce what Dr. Bain was saying, both with adaptive equipment and then the built environment.
Are also explicitly asked, does KAND short? Yeah.
So that's something we're really still learning. That's something that it's a hard question, and it's something that, from what we know so far, this can really vary depending on the variant. That there are some of the variants that what we're seeing is that those people tend to be more severely affected. So far with KAND, we have not seen people have complete 180s. So if somebody has a disease that's generally more severe or generally less severe, we would expect overall that trend would continue. But it's difficult to say anything more generalized about lifespan.
One other thing I'll note that's not directly related to KAND, but is indirectly, is for individuals who have difficulty with communication, there may be something going on that they're not able to communicate. So let me just give you one example. I've had patients who had appendicitis, and it was hard for parents to know, was this just some of the neuropathy or some of the spasticity, or was this something different? And so there was a delay to diagnosis for appendicitis. Then the same thing can come up for other things. And so that delay to diagnosis increases the risk of a complication of whatever that is. And it just becomes, it's no one's fault in terms of this, but it does make it harder. What I'll say, and I know I feel like a broken record saying this, is that you know your child or your loved one best, and you need to trust your intuition that if your person is off, be able to advocate for them when you're going to the emergency room or calling your pediatrician or internist to say that something, I don't know what it is, I don't have that level of specificity, but I know something's wrong. And again, that working relationship with your provider, that they're going to take you seriously and perhaps need to do a bit of testing to figure it out, but they do take you seriously.
That kind of leads into another question that is probably one of the most frequent questions we get in the community is, knowing that we have deaths in our community, a lot of parents want to know, is there something in particular I need to be worried about or watching out for? Is it seizure related? Is it aspiration? Is there anything we can do or should be looking out for?
So far, the deaths we've had in the community, I don't think anything's been a complete surprise. So in other words, what I'm saying is someone who was sort of walking and talking one day and then died in their sleep and wasn't with us the next day. We haven't seen anything like that. What we have seen, and I think we know we're a small enough community, we know these things, that we've had individuals who've been pretty severely impaired to the point that they have probably aspirated or had a series of aspirations. So in other words, what I mean by that is something going, instead of going down the gastrointestinal pipe, goes down the windpipe and then goes into the lungs and causes an infection. And those, again, happen to many. If they happen, are more likely to happen in children and are children who have severe issues. Epilepsy is the other portion of this, and thankfully we haven't been having sort of sudden deaths in terms of that, but we have had kiddos that we knew weren't doing well for a while and then having those issues at the end with that. So those are the two areas that I get most concerned about. But like I said, I thankfully it hasn't happened yet. I'm knocking on wood here on my desk here. But like I said, I think we still need to learn and be able to talk with each other about this. But in particular, that's why we were emphasizing the seizures so much and making sure we're constantly assessing for seizures, even at times where we're not observing them, but they may be happening.
Yeah, and Dr. Bain, did you want to add anything?
Yeah, as a neurologist, we often are the bearers of bad news, and I think our job is not to do that. It's to say this is the information we have and be available to predict and provide the best support we can. There's unfortunately a sudden death associated with epilepsy. It's called SUDEP, and I think it's. The goal of me bringing it up is not to bring down the party. It's really to build awareness and also confidence and understanding that luckily there hasn't been anybody reported with this, but this is an important topic that anybody with seizures should be aware of. It's the term is sudden unexplained death in an epilepsy patient, and so any individual who's had a seizure before. We do know, and this is not related to KAND, this is anybody with any reason to have seizures. And really what happens is what we're recognizing more is that the most important thing is to have a neurologist, to be taking your medication regularly, not missing medication. And those are the most important things to be doing. And so I think luckily it's certainly not reported as in this group, but it is something important to be aware of and something to be taken seriously. And I think one of the difficulties now is knowing that half of the individuals, or almost half, might have had seizures, and some have been treated effectively. Most of them seem to have been. It does seem like that, but there are some that we're not sure whether things are seizures or are not seizures, and that's where the gray zone is and what we're still trying to understand. And so I'm happy to answer more questions, but I do think that's a topic that should just be on the radar of the group, given that seizures do happen and when we can control them with medication.
Right. And that does bring me to another question that was submitted ahead of time. And this is a common question in our community. It seems to be really difficult, if not impossible, to tell the difference between a seizure, or maybe it is an optic nerve issue or a vision issue, or is my kid just daydreaming? I know we hear that a lot from our own physicians. Like, if you can have them snap out of it as you're saying their name, then it's not a seizure. But I mean, can seizures happen at 1 second, 2 seconds at a time? So yeah, how do we tell?
I'll tell you that sometimes it's hard to tell, and sometimes it's even hard to tell when you have that EEG information. So I'll say what a seizure is. It's a buildup of electrical activity that starts in part of the brain and kind of builds up over time and then kind of goes away. And so in general, most of the larger seizures we think about are those shaking seizures or stiffening seizures, and they typically do have to last a certain amount of time to be called a seizure or classified as a seizure. The ideal situation to say something is a seizure is to do one of those EEG tests, have an episode, and then say, okay, was that a seizure or not a seizure? Unfortunately, my car often makes noises, and when I tell my husband and bring it to the shop, it doesn't make the noise when it goes there. And then we're left with, it was making the noise, but I don't know whether that's the problem or not. And so if you go for an EEG, you don't have the episode, sometimes it's really hard to say yes or no, that's not. And so ideally, EEGs can be very helpful, but they're not all the information. And so sometimes we don't capture those episodes on an EEG. I'd say in general, if your child has staring spells, I know people have made comments about a therapist saw a staring spell, or I'm not sure if my child's daydreaming. The best recommendation I can make is you go up to your child, you call their name in their face, not from across the room, right? You try to shake them a little bit, get their attention, and see if they kind of, snap to it and come with it. If they don't, then I agree, that is very concerning. Luckily, we do have good technology out there. So we have our cell phones and our tablets. So I think if these things start to happen in patterns, use that technology for good and take a video of it. The more videos you have, the better to provide to your clinician and your provider, and then they can hopefully put that together. Another thing that could be very helpful, aside from taking videos, is taking a diary. So write down a diary with your providers. What are the episodes that are happening? Describe what they're happening, when they're happening. Seizures don't care about where you are or what time it is, okay? So if you notice that your child is doing a funny little staring off spell every day when you're going into lunch and you only put them in the high chair, that's probably not a seizure. But seizures will happen here and there and this time and that time for the most part. So, really, I think keeping a good diary of when those episodes are happening could also be very helpful. One thing to know is that those EEGs, even if they don't capture that specific episode, they will give us information about how the brain is kind of resting and in between those episodes. And then it really is up to your doctor, your clinician, to say, what is the risk with this information? Do I think they're going to seize or not? And, it's not uncommon for that to be a discussion and not a black or white yes or no. Okay. So I think having a doctor that knows your history, knows your medical condition, and also knows kind of what's going on is really important. And recognizing that there might not be a 100% correct answer right in the moment. As a neurologist, we often say, well, we're going to know as time goes on whether this will become seizure or will fizzle out. There's some comments here in the chat I'll just address about EEG. So one thing to recognize, I think somebody asked, can the EEG indicate if the child had a seizure? It only will tell you if a seizure in the moment. So it won't say like, oh, yep, that thing you had 5 years ago, that it won't tell you that. It only tell you when you have it on, whether there's a seizure at that time, okay? But it could tell you, and it could be abnormal, it's another question, in between the episodes. So how the background, we call it the background of the brain, has some abnormal episodes. For example, some individuals might have electrical activity that shouldn't be there. And that tells us sometimes that you're at risk to have seizures, even if you're not having a seizure on EEG. And just to finalize that, somebody did comment about, if my child hasn't had a seizure for 2 years, can I come off the medicine? That's a rule of thumb. It's just a general practice guideline that if somebody's been on seizure medicine for 2 years and they haven't had a seizure, it is worth considering coming off medicine. Now, that is the case. However, if we know that that person still is at risk having a seizure due to an underlying genetic condition, or they do an EEG and it's still abnormal, there is still a risk that they could have a seizure. So it's absolutely a question and should be a conversation of whether they should stay on medicine or not. But the answer might not be, yes, it's safe to come off medicine at that time. And so I think that's just important to say, just because it's been seizure-free for 2 years doesn't mean you're completely free to take off medicine and you won't have a seizure again. That's just our kind of general, well, if we think you're well controlled for 2 years, we think there's a shot that we could potentially come off the medicine.
I wanted
Dr. Boyle, yeah.
Oh, I wanted to just highlight something that Dr. Bain said that I think connects to something Dr. Chung said earlier. You know your child, you know yourself best. If there's something that you see that's abnormal, taking a video is a really great tool. That's something that way you can yourself compare a video on day 1 from a video on day 2, and you can share those with your providers. And seizures or things that look like seizures, that's one example. Also, if you have abnormal movements that you're seeing, any of that, that's one of the really nice benefits to the fact that most of us have these cameras in our pockets all the time. So just keep that in mind. If you see something and you can snap it, that's very helpful for us.
I see a question in the Q&A floating up to the top from Luke. He says, could seizure activity in the area of the brain responsible for vision be responsible for some part of CVI?
Luke always asks really good questions.
Dr. Dad.
Very good question, Luke. You had me on that one. So the back of the brain, called the occipital lobe, does control our vision. Your eyes connect to your nerve, and that trickles back to the back, and that controls your vision. We do know that seizures in the back of the brain often will present with some visual findings. There's not a clear understanding of where CVI comes from. And so I would say that it's a great question and a wonderful hypothesis, but at least to my knowledge, we don't know that specific spot only will cause CVI. I think in general, we think CVI is more of a network problem of the whole brain. And so for whatever reason, it's not necessarily that specific part of the brain alone. It's more of a network issue with the brain causing that misunderstanding of vision.
Okay. Let's see. The question that was asked, I want to come back to about, maybe can we wean off meds if we've not had seizures? I'm wondering, Dr. Boyle, from the natural history study data, there seemed to be an increase in seizures kind of later on in late teens or early 20s, maybe. I mean, should we take that into consideration when figuring out if you're, in those teen years and things are going well, should we come off meds or stay on?
Yeah, I think that's exactly a very good point to make, and we need to stay vigilant, that because in KAND it's something that we don't just see seizures happen for the first time at age 6. This is something we can see happen in the teens, we can see happen later in life. And so in that conversation that, as Dr. Bain was saying, you should have with your child's neurologist, it's worth considering what the risks are. And if there's a medication that has kept your child seizure free for a number of years that they're okay with on a day-to-day basis, then thinking about if there is the possibility of developing more seizures later, consider this in the equation. I think that's a very important point.
One thing I'll echo is that not uncommon. I'll give an example for people to be reporting only some symptoms, right? So you often will only hear about restaurants and the bad things that happen, but a lot of people don't talk about those good things. So it's just as important for people who aren't having seizures to report that they're not having seizures, because unfortunately, we don't want to bias ourselves to say, well, these are the seizures and they're really bad, but all these other people aren't having seizures. So everybody really has to advocate as their person to say when they are or are not having these symptoms, because otherwise it's just the squeaky wheels that are getting a lot of attention. And if not everybody is having hard to control seizures, that's just as important as those people who are having hard to control seizures.
So I'm just thinking out loud, so apologies, but Jen, Leah, help think with me. So knowing that this is dynamic and that in general things are going to get worse rather than getting better, or hopefully stay stable. Sometimes in kids, Jen, we let kids outgrow their seizure medication, right? So in other words, as kids are growing, even without changing their dose of medication, it's sort of diluted in their body and they're outgrowing it that way. So one question is, if you've been seizure free as a way of kind of tapering off, what do you think of that idea? And in general, I'll just tell you my gut feeling is that I'd rather be on the conservative side about continuing the treatment for the seizures, knowing that it changes over time, unless you're having real side effects from the medication. And that sort of changes the equation for me. So Jen, what do you think about those points?
I think, there are some times when we have a seizure because there's been some kind of hit to the brain. All right. So a seizure is just some kind of symptom of something going on in the brain. And our question as a neurologist is always ask what happened. So sometimes people will have an injury in adults, for example, not KAND. You have a stroke or something, and then you have a seizure. And then once that gets fixed and once that goes away, kind of the risk goes down, right? We're talking about something different here. And so we're talking about kind of that general, my brain has developed at an increased risk to have seizure. I don't think we have enough information to say whether that increases or decreases over time. My concern about outgrowing medication is that we don't really know what to do with that. So it's like if you have an ear infection and you just take a day or two of medication, you're not really treating that infection. To me, there's a minimum dose that you have to take based on weight. And so, I think realistically, we want at least that minimum level to say that's productive. If you're not taking enough, then it's just probably not doing anything. So sometimes we will take that into account. Like if you're on a really low dose of something, you're probably not taking, it's really probably not doing anything for you. I think in general, most doctors will say you're not going to outgrow the medicine. We are going to increase it to at least give you the minimum protection. If we're concerned you're going to have a seizure, we're going to protect you against that. So I think my gut as a neurologist is to say, no, if I'm worried you're going to have a seizure, I want you to be on the medication. I don't want you to be on not the correct dose, because then it's not doing anything.
So just a little bit of data, and it is a tiny bit of data, so understand that. But we have had exactly, I think the number is 2 of individuals within the community who were stable with their seizures and then went off the medication, but then then had the seizures come back and recur. And when they did recur, and it was probably just the course of the condition. I don't know that it was the stopping and starting of medication, but they were difficult to control afterwards. And so again, my gut feeling is, as long as there's not a severe side effect or problem, better to stay stable and stay on the medication, even if things look like they're doing well. Just take that as a win, but continue the medication.
I agree. I tend to agree. I mean, it's really risk and benefit. And I think similarly with side effects on medication, parents are often, I don't want to go on that. I've heard such horrible things, but you don't hear about all the wonderful people who have taken medicine and it's been fine. Somebody asked a really important question, and I think this is a really good one. So they said, if a seizure is happening 1 time a month, is that considered uncontrolled? So control is based on the individual. Okay. Some people, I have a goal as their doctor to say, I don't want you to have a seizure ever. That's good control. And some people, they have much more difficult to control seizures, and they might have 10 a day, right? So I think understanding that each individual is very important. And so uncontrolled is going to be based on you and your specific situation, and whether or not we consider that control or not control. It's not uncommon for breakthrough seizures, meaning you're on a medicine and you have one, to happen in some situations. You might be sick. You might have missed a medication. You might have grown significantly and you weren't able to go to the doctor because a global pandemic hit. And so we didn't know how much weight you gained and we didn't get to go off on medicine. That doesn't necessarily mean you're poorly controlled. There just might be other factors for why you had that breakthrough seizure.
There's another important question and another common question. Is there any value to taking seizure medication if there hasn't been a seizure yet, but an EEG is abnormal? So can we do preventative seizure medication?
It's a great question. So a seizure can look like different things. So people will say often, I don't know if my kid had a seizure. So you could say, my child never had an episode that I saw that was concerning for like a shaking convulsive seizure. But absolutely, we don't know if a staring episode perhaps in the past was a seizure. It will be a conversation of what's the risk, how bad is this EEG, versus, the likelihood to have a clinical convulsion. And I think we don't really know. I do have patients with KAND and with other neurological disorders where we say, based on the information I have, I think you're at high risk to have a seizure. Okay. And sometimes it might be that you take an EEG at one point and you decide, you know what, we're going to check again in 6 months or a year and see whether that risk has changed. I think that's sometimes a conservative, we're going to wait and watch and get more information to have 2 time points instead of just 1. And I've seen it go one way where you say, yeah, I think we're still at risk and we're going to go medicine. I've also seen it go the other way where people say, actually, it got a little better. So we're going to just wait and watch. I think if you're concerned about seizures, there's any abnormalities, always ask your provider whether you think, number one, is there a role for preventative medicine? And number two, is there a role for that rescue medicine? Because sometimes that could be another option as well.
I want to shift gears a little bit, but your comment about, hearing all of that data, like, are you having seizures? Are you not having seizures? And one of the things that I love so much about the natural history study is that it goes through every single body system. And so, you don't know what you don't know, right? And so it seems like we've been able to pick up on some small trends in KIF1A that weren't picked up before because no one was asking. And one of the things that we're seeing more and more as the community grows is just this reoccurring problem with bladder, urinary, or kidney infections. And so I don't know if you have any insights about that. Is this a very rare problem within the rare KAND community, or is this something that could also be underreported? And is there anything we can do? Because again, a lot of these families are talking about very difficult to treat infections that keep reoccurring.
So I'll say a couple things, and I think Leah probably will want to chime in. So when we started looking at things, we were, just to give sort of the contrast to what Kat is saying, there are a number of parts of the body that we haven't been seeing affected. And that's actually been a relief to me in the sense of the heart, for instance. We haven't really been seeing heart conditions. From very early on, Leah and I were starting to see even some developmental differences in terms of the we call it the genitourinary system, but the reproductive system and the kidneys and the plumbing that down there basically is a way to think of it. And I have to admit, I was a little surprised at the beginning and said, is this real or is this just a coincidence? But it seems to be, as Kat said, because we've done it so rigorously and everyone's been so good at reporting in, we did see very early that I do think this is real. I think in a good way, it hasn't been devastating, but I do think it is something real. The other thing we see sometimes in children with disabilities, and I have to say girls are a little different than boys because of the plumbing down there, is that sometimes there can be issues. And for women, you know that women are more likely to have urinary tract infections than men are, right? And so we're seeing some of the same things in that. And part of it has to do with hygiene and just some anatomy issues. And part of it also, as I was saying before, is that we may not know when kids are symptomatic. So if they're not able to tell us that things brew longer, what was like if you had been noticing that it burned when you peed, you would have realized it and gone to your doctor and said, I need some amoxicillin or something in terms of treating a urinary tract infection. Whereas some of our kiddos, they appear off, but we haven't localized it to know exactly what's going on and to make sure it's easy to treat at the beginning. It just gets more complicated as time goes on. So one of the things, and again, going back to the clinical care guidelines that we will put in that, this is a place to be alert simply because it's so easy to test for and to, just be able to catch a urine sample and test for a urinary tract infection and be able to make the diagnosis quickly. And it is easy to treat and clear up. One of the things I'm watching for is that if the anatomy is different though, so if there's something called urinary reflux where urine goes back from the plumbing back into the kidneys, and if it does that when there's an infection, then it goes from being just a bladder infection, which is relatively easy to treat, to an infection in the kidneys, which is harder to treat. And there can potentially be longer term damage to the kidney for that. So just as something for those of you taking notes, one of the notes to take and to be aware of is to make, if there feels like something's off, if you've got a child with an infection or a fever and it doesn't seem to, you don't know where it is, it's not a cough or a cold, your breathing problems, do check for a urinalysis and a urine culture. Have your, just whisper in the ear of your doctor, can you check the urine doc? And that can be something in terms of quickly being able to see that. But it's that double whammy, I think, that's getting us into trouble there. So that is thankfully one of the few areas outside of the nervous system, essentially, where we're having issues. I will say very briefly, tummy problems, gastrointestinal problems, we are seeing some issues where I do think that's related in some way to the brain. So even though it feels very different, I do think it's related to the brain and some of the problems that people have been noticing in terms of infections, lung infections, as I said, whether it's aspiration or whether it's a cough that just seems to go into a pneumonia or get worse. That's also at the end of the day related to how the brain is working and how well the children are able to protect their airway from things going down the wrong way. But those are other places to be able to be mindful of and keep an eye on.
Okay, and I know, I think we want Dr. Boyle to weigh in too on that issue, but I'm wondering, is this reoccurring urinary and kidney infection issue, is that common with spastic paraplegia, or is this, more related on a molecular level with KIF1A, or is it both?
So I think probably to a certain extent, this is one of the areas where we really need more information from families, because this wasn't something that we looked for it, because as you were saying, we wanted to get the big picture of everything that's going on. But this is something where we know, for instance, with spastic paraplegia, urine incontinence, so the inability to control one's bladder, that is a common symptom in spastic paraplegia, whatever the cause is. So that's something that we can think of as connected to the brain or the nerves in that way. And that's something separate from KIF1A, which is something that in general, when certain nerves are affected, you might see that as a symptom. When it comes to some of the structural abnormalities that we've seen, that's probably KIF1A related, but that's something where it's still a very small number of people that we're seeing that. We really need to better understand what's going on. I think some of the things that we're discussing, things like, for instance, urinary tract infections, a big question is what's causing that? And this is, as Dr. Chung said, something that if this is something we're only seeing in girls and not seeing in boys, that would tell us something slightly different than if we're seeing equal amounts in girls and boys, that we just really need a lot more information. And so this is something where this can be one of the things where if something comes up for you or your family member, feel free to shoot us an email, even if it's not necessarily part of the official follow-up, that it's really good for us to know these things, because we don't know what you don't tell us.
Right. Yeah. And just anecdotally, I'm hearing equally from boys and girls that, they're struggling with these issues. But again, I think it is, it's not super common, but it's there. And I think when it does happen, it's significant enough that, these patients are having to be hospitalized in some cases. So it's a big issue. So to shift gears again a little bit, something else that I don't think we talk about enough is the behavioral challenges and issues that we can deal with. So, we had one parent write in a question that said, we're struggling a lot with behavioral issues, ADHD, anxiety, anger, and tantrums that last nearly an hour. I'm worried as my son gets older, we won't be able to handle his more violent outbursts. Can medication or therapy help?
I'll let Jen chime in, but I'll start off. So I would, number one, although medication I do think can help, I would also try and do things that are not with medicines before. I think in terms of some of the anxiety, it comes from things that are new, situations that are new and surprising. And so as much as you can do in terms of being able to have a routine, set expectations, and be able to anticipate when things are going to be new and prepare someone for that. And so this is not KAND specific. It's similar to strategies that we take for other conditions. I use visual schedules and visual charts as a way of being able to do that and have something for weekdays and weekends being different. I would say COVID has thrown everything out the window, as we've said before, but I do anticipate that this fall things are going to get back to usual in terms of doing that. There are some things, and I do think, although many of our kiddos are young, similar to some other conditions, when hormones start to come into play during adolescence and puberty, I think we're going to have some rocky waters for a little bit of time until, and by the way, for those of you who have teenagers or adolescents or have had them in the past, that's its own condition, right? That's unrelated to KAND, just everything sort of shifts during that time. And KAND kiddos are no different from that, but that does just hold on for your horses for those of you as you come into that period. Things will change a little bit at that point. And I'm also, by the way, watching carefully to see what happens with our seizures during that period as well. But as we do, I think everything you can do in terms of being able to do from behavior modification, and for those of you who need that help advocating in your schools, being able to have a para who's able to take someone out of the room, de-escalate situations, being able to see when things are starting to bubble over and being able to intervene early, all of those things can help, but sometimes medications are ultimately necessary. I'm going to let Jen talk about medications, but I will say medications for me are complicated, and it's actually 3 issues that are all related to the brain, but they're very much interwoven. So part of it is related to the epilepsy, part of it is the peripheral neuropathy, and the pain that can come with that, and then part of it is related to the behavior. And in fact, some of the medications that we use in other people to treat one symptom in a good way could actually treat more than one symptom or spill over. And it's complicated because some of our kiddos haven't gotten to the age where they're starting to see this complex interplay. And I do think we're going to have to get really detailed with some, I'm going to use the term measures, and I'm going to warn you in advance that we're going to be giving some of you some very detailed surveys that are going to try and get at multiple dimensions of this, so we can get really granular detail about what's happening during certain periods of life, or for certain of you that are having more and more challenges. But Jen, I'll let you comment on the medications and how these might interact to affect more than one symptom.
Yeah, no, I think one thing to recognize is that the emotional aspect, or these are behaviors we're talking about, right? So behaviors and feelings, which are on the outside. So anxiety, anger, aggression, ADHD, right? These are behavioral, what we call phenotypes, symptoms we see on the outside, and they're caused by something going on inside. And so absolutely, it's not uncommon when you have something that affects brain development to start seeing these behaviors change. The threshold to treat them is very different than, for example, somebody who has seizures, right? You have a seizure, we say that could be damaging, you need to treat that, okay? When we're talking about treating behaviors and treating symptoms, personally, professionally, I think about when those behaviors or those symptoms are affecting an individually, right, or are limiting them. So that really is a personal decision and a personal discussion between you and your provider. I think that all individuals have peaks and they have valleys, right? Which of those valleys are really problematic? If a child comes to me and their aggression or their impulsivity is dangerous to them, then those should be put forth as this is something we should be treating with medication. If, for example, some kids are a little more fidgety and it doesn't really affect them, okay, I'm okay with that, right? So I think it is an ongoing conversation between you and your provider about whether these are behaviors that intrude or are safety concerns. So I don't think there's always a right and there's always a wrong. But recognize that when you are treating, as Dr. Chung said, importantly, when you are treating some symptoms like seizures, sometimes those medications can be either positive or negative to treating these behaviors otherwise. So recognizing that medications that affect the brain can affect a lot of different things. And so sometimes they can be helpful and sometimes they actually can affect things poorly. So I think just recognizing that it's not just one piece that you're treating, you have to treat the whole person, and that those medicines similarly can not only affect that one piece, they can also affect the whole person. It's going to be an ongoing discussion between you and your provider. The natural history study will hopefully provide recognition of when things are worse. For example, how will puberty affect our mood and our behaviors? How will right? COVID is a whole separate situation, but like how will seizures change our personality if that comes about? How about changing into adulthood? So I think that's where hopefully the power in numbers will provide us with that guidance of, being prepared for things. That doesn't mean your child will absolutely have difficulty when they hit puberty, but just recognize that might be a difficult time. One thing I will also add, I always remind parents, your child is not your child is not only that diagnosis, but they're also their age, right? So toddlers are toddlers and teens are teens, and they're also personality. So they're allowed to have their own personality. So you can't just look at that diagnosis and say that's everything. There's different factors involved. They're allowed to be a teenager, and they're also allowed to kind of be a feisty lady. Like they are who they are. And so, there's different pieces, and some of that you should be treating, and some of them you should just be accepting that's your teenager. So it's a very complicated equation, I think, altogether.
That brings me to another question, actually, that I think this parent submitted a question in our private family group thinking that maybe they were the only one. And it's also wondering, is this like just my kid thing or is this a KAND thing? But it's basically about what sounds a lot like night terrors, or even after the question specifically says, ever since our child was young, he would wake up shortly after falling asleep screaming, seemingly disoriented and unable to sleep. Take a long time for them to fall back asleep. And then you just see the comment section in our support group just take off, and everyone is chiming in like, yes, you know, very similar experiences. And so could this be night terrors? I think some of our parents are worried, is this some kind of a seizure that I should be worried about? Or is this just a normal kid thing? So do you have any thoughts on that?
I have 3 kids, and my third had night terrors, and it was awful. So I'll say that it does happen in kids, but I don't think we know enough to say this is part of, obviously, if there's a lot of parents saying this, it's certainly an area that should be brought up. Sleep issues, we know in any neurological disorder, is more common. So I don't know, and I don't think, Leah, that, or Dr. Chung, that we've included there's specific sleep questionnaires, and maybe that's certainly something that could be intrusive to many families as a parent and a family member, but it's definitely something that could be looked into a little bit more, to say, looking at everybody, what are the sleep patterns and what are the issues there? And then absolutely, when we're talking about seizures, you can have seizures in sleep. And so when you do those EEG tests, it is important to sometimes get the overnight EEG as well, because there are certain patterns that can be seen on sleep versus awake states. So I think definitely we should include some sleep questionnaires to the group to see what's going on there. And then number 2 is EEGs should ideally capture those episodes overnight. Some people might have access to formal, what we call sleep studies, where they do have sleep specialists who can look into that a little bit more. But certainly the EEG should be done overnight if those types of episodes are happening.
Another random question, but with COVID, this has kind of become more relevant, I think. But this temperature control dysfunction with KIF1A, like some of our kids just randomly run fevers. And so I guess why is that? And then how common is it with KAND? If I remember right from the natural history study, I think it was about half of the population had reported this, but why does KAND cause this temperature dysregulation?
So I'll take a first pass at this, and then Leah and Jen may want to chime in. So temperature dysregulation issues are not uncommon for other types of neurogenetic conditions, and that's because there's a part of your brain that's actually responsible for temperature control. And so as we see differences with that, then we can see differences. I actually was anticipating, and in fact, it was borne out exactly as you said, Kat, when we had to check our temperatures on our kids before they could go into the classroom every day, that we were going to see evidence of this. And in fact, in some cases, we've had to write notes in terms of getting exemptions, you know, that this is, even though this temperature is officially a fever by your standards, this is just regular temperature, you know, for Johnny. And so that's been something that hasn't been KAND specific, but we've seen across other conditions as well. The other things sometimes we see that parents report to me are, even though the temperature, so if you were to take the temperature of the ear, the forehead, under the tongue, something like that, even that, though that might be okay, you see some things, for instance, in the hands or the feet, where you'll see things get really red or get really blanched. And so some people may know about Raynaud's, they may have it themselves, and whether it's in the summertime or the winter time, it can go back and forth, and it's not always necessarily based on outside you're hot, and you know, so things are hot, it can happen both in hot or cold, sort of reciprocally. That also has to do with what's going on in terms of the nerves that are going to what we call the periphery, and what happens in terms of being able to get blood supply and blood flow going to different parts of the body and how that responds. And so that's part of something that we call the autonomic nervous system, and there are dysregulation and problems with that as well. So those are both fundamentally related to what we see in terms of brain, and the brain being different in these cases. To my knowledge, it's not causing problems per se in terms of, you know, I don't think we're having huge numbers of febrile seizures, or that being sort of the kindling to have the epilepsy come out. So I think it's just good to know what normal is and normal isn't. I did bizarre, some of you will think I'm a little bizarre, but I actually did do some experiments for a different group where we put temperature. They looked like these little sort of battery buttons, but we had temperature thermometers that we could put on people over 24-hour periods and be able to see these in cycling and see what happened. And that's what's convinced me that what I said, I haven't done it for the KAND community, but I've done it for other neurogenetic communities, and it's definitely real in terms of doing that. And like I said, it's just a matter of recalibrating to know what's normal for your child so that they don't have to get sent home from school all the time. Jen, did you want to say anything? Or Leah?
I think it's unfortunately the temperatures is just such a tricky thing to study in groups, in humans especially, because it's controlled by like really deep structures of the brain. And so it's definitely complicated. It's certainly something we are aware of and might be related to some of the other symptoms, but I'm not sure it necessarily means anything at this point.
It does remind me of a question, another good question from Luke in the Q&A about just random connections. So one of his questions was, can seizures be happening in the stomach? And can it be cause for some of our kids' stomach and GI problems?
So the gut has this meaning, like anywhere along the guts and the intestines is so cool because it has its own brain. And probably, I don't know, 25 years ago, 30 years ago, we didn't know much about it. And there was like a line in a textbook about it. Now there's like chapters in textbooks about it. And then I would guess in like a decade, there's going to be like entire textbooks written about it. There's what we call the brain-gut interaction and the brain-gut axis. So absolutely the brain and the gut are kind of working together. And then there's an entire nervous system or brain in the gut itself. I don't think we have any evidence that there's seizures per se, because they're not that type of brain cells that you have, but there's certainly a connection between the brain and the gut. And there's certainly some weird things that can happen in the gut itself. We think that is related or unrelated to the brain. So I don't think you can necessarily have seizures, but maybe in 50 years, we'll know more about that. But the gut is certainly very important when it comes to neurological disorders. People often ask me, should you be on certain diets if you have a neurological condition? What I will say is that if you eat better, you will feel better, right? If I ate McDonald's every meal for an entire week, I would not feel well, and my behavior would not be very good. My sleep would be messed up. My gut would be messed up. People around me would not be very happy. So, certainly eating better will lead to better outcomes for the brain, as well as for seizures. But it is probably more complicated than that in general. Great question, Luke.
And I think we're going to run over just a few minutes late, but we'll just cut into our break later. I want to ask the question that has the most votes right now in the Q&A from Madeline. And she says, it might be a matter of a mother's perception, but to me, it seems that cognition is very heavily affected, while the emotional aspects seem quite okay. And do you have any thoughts on that? And I don't know, maybe, again, it's hard to generalize with KAND, because I know we also see a lot of behavioral and cognitive issues going hand in hand with others in the community.
Maybe I'll start and others can chime in. So I will say, in the universe that I live in with a lot of other conditions for comparison, I think in a good way, we've been relatively lucky that although we did talk about externalizing behaviors and tantrums and things like that, that's not as common with KAND. And so I do think in general, and I feel like giving your kids all a sort of big group hug right now, because they are so warm and cuddly and friendly and smiley, and they're great in terms, and I think they're going to stay great, by the way, so I don't want everyone to have a panic when their child turns 12 or 13. But so I do think we've had relatively less of that. Exactly why that is and what parts of the brain and what circuits are affected in terms of this, I don't think we've gotten to the point of that neuroscience to be able to know that specifically, but just as an observation, I'd say that's true. And for the adults that I know in the community, that's been true as well. So I can't tell you why, but I do count it as a plus for us in general. So not say that it never ever happens, but it's definitely less frequent.
I'll just add that I think it's really important that the question be also expanded to, well, it might be the emotional issues for that person, but it is also a family affair, a parent affair, and there's other people. It's complex. It's not just the emotional well-being of that individual, but it's also the family, the parents, the caregivers, the siblings, and the family dynamic. And so the mental health of that specific individual is just as important as the mental health of everybody around. And so typically when patients come to me, I say, we'll deal with your child first, but then guess what? After that, we're talking about everybody else.
Please do.
So I think that's really important to recognize that it's not only the emotional aspects on that person, but also everybody else who's taking the burden and who's involved in this family affair.
Yeah, absolutely. And so I knew that we weren't going to be able to get through all of the questions we wanted to get through, but I think Shannon or someone said we will reach out to these wonderful experts and get some written answers from them that will disperse into the community. But I do want to ask one last question, and I think this might help transition later in the last half of the sessions today whenever we hear from some of our therapeutic development collaborators. I think the most common question we got ahead of this conference from the community was, is there any hope that treatment can help with these cognitive symptoms? And, you know, I think we've talked about this a little bit throughout, you know, the previous sessions, but you know, because that does make such a big impact, and it really affects everything from, you know, communication, and it also, you know, it affects things like safety issues, you know, helping my son understand that, no, you can't just go down the stairs on your own, you will fall and you will hurt yourself, you know. And so are we seeing any success stories in other similar communities where treatment is being developed, where they're seeing improvements with you know, cognition or even communication?
So I think fundamentally, and we'll talk about it later this afternoon, if a treatment is successful, I think if it's getting at the underlying molecular etiology. So if it's really treating the KIF1A problem directly, assuming it gets to all the parts of the brain that we need to, all the parts of the nervous system, it should help cognition in the same way it's helping the other things, whether it's epilepsy, whether it's neuropathy, it should be able to help all of those things. I think the big question to me is, can we get something that does that? If we're doing something that's symptomatically a pill that's treating the neuropathy or a pill that's treating the seizures, I think something that treats seizures helps in terms of the brain functioning better. So I do think you get a 2-for-1 in that way, but something that's just helping the painful neuropathy, I'm not convinced is going to help with cognition, if that makes sense. So I think there's some symptom relief and directly looking at symptoms, and then there's some core trying to fix the KIF1A. And if we can get to the core trying to fix the KIF1A, that's where I think we've got the most promise in terms of being able to talk about all the different symptoms we're talking about. I do want to say, though, that I'm not sure, and I'm going to use the term reversibility. I'm not sure when we treat if we're able to go back up the hill, is the way I'm going to describe it. So if we can go back up in terms of regaining function, I think if kids are in a developmental phase where they're developing and they're, you know, gaining skills over time, I'm hopeful that we can get better on a better slope and, you know, increasing over that. But if someone were, you know, a fully formed adult, for instance, if there's something that's been done, I don't know that we'll be able to undo some of the damage that KAND has done. I just want to be realistic about that. But of course, we're going to try every different molecular trick that we can to be able to get it working everywhere, for every person we can.
Well, again, thank you all for being here and for working with us over the years and into the future. I think our community is standing by and ready to answer whatever surveys or you know, feedback that you need. We're ready to engage and help move things along. And so now we will turn it back over to Dr. Dom. And we'll have a good rest. The last half of the conference, I think, will be very informative and exciting, especially to hear from some of these therapeutic development collaborators who are working so hard to help us address some of these really concerning symptoms we've been talking about this morning. So thank you all.
Thank you all.